Welcome everyone to this first session in the National Seminar Series for our Geriatric Psychiatry subspecialty residents. Before we begin, I'd like to start with a land acknowledgement. So I'm coming to you today from Newfoundland and Labrador, and I would like to acknowledge the island of Newfoundland as the ancestral homeland of the Beothuk and the Mi'kmaq people, and Labrador as the ancestral homeland of the Innu and the Inuit. I encourage you all to use the chat and to tell us where you are joining us from and to share a land acknowledgement as well. All right, so while people are doing that and while I'm continuing to let some people in, I just want to introduce our two speakers. I'm so thrilled to have them both today. I'm so excited they came to speak to us today about psychotherapy in older adults. So I will start with Dr. Gojmerac. She's a licensed clinical neuropsychologist who obtained her doctorate in psychology from the University of Toronto and completed clinical training at Baycrest Health Sciences with a focus on aging and brain health. She's currently working as a staff neuropsychologist in the Seniors Mental Health Program at St. Joseph's Healthcare. She provides neuropsychological assessment and cognitive remediation. She also has experience providing IPT, CBT, and BA to older adults. She has an academic appointment with the Department of Psychiatry and Behavioral Neurosciences at McMaster University and sits on various committees, including the Psychiatry Subspecialty Competence Committee. She is actively involved in the supervision of clinical and research learners. Welcome. And next we have Dr. Erin Hanley, who is a geriatric psychiatrist for the St. Joseph's Healthcare Seniors Mental Health Program and assistant clinical professor in the McMaster Department of Psychiatry. She completed her undergraduate degree in life sciences at Queen's University, medical education at Trinity College Dublin in Ireland, and psychiatry residency program at McMaster University. She graduated from the Geriatric Psychiatry subspecialty residency program at McMaster in 2019 and works as an outreach geriatric psychiatrist for the Niagara and Brant Seniors Mental Health programs, and has an additional interest and role in the psychotherapy program for older adults. So thanks to you both. I'll invite you to get started. And if there's any questions, we can get them in the chat, and hopefully there'll be time for discussion as well at the end.
Great. Thank you, Kathy, for those introductions. So welcome, everyone, and thank you for joining us today. So for the next 45 minutes or so, we'll be presenting on psychotherapeutic interventions in late life. I'm hoping that we can leave a little bit of time for questions and discussions at the end, but please jump in at any point. I'll try and pay attention to the chat function, but if I don't see it, just flag it to me. But also please interrupt anytime if you have questions. I'll try and stop periodically as well to see if you have any questions. So we can make this as interactive as possible. Okay, so for today, the objectives are to review the evidence of psychotherapeutic interventions in older adults. And we opted to focus primarily on depression and anxiety, as that tend to be most relevant, but also you'll see that that is where most of the literature has been conducted. And so for that reason, the focus is primarily on anxiety and depression, and also just in the interest of time. We're going to look at the indications for psychotherapy and considerations for delivering psychotherapy in older adults. We're going to spend a little bit of time on psychosocial interventions. And we're also going to look at some of the current challenges and potential future directions. Okay, so looking at the evidence. So first, these are, listed here, the psychotherapies that primarily have evidence for late life, mainly depression in older adults. And so what you'll see here is we've got CBT, BA, problem-solving psychotherapy, interpersonal psychotherapy, mindfulness, and reminiscence therapy, life review. Some of you may have had exposure to this in your general psychiatry training and done some training, and on other modalities you may not have. But in general, these interventions tend to be offered either in individual or group. CBT focuses on, there's a component of behavioral activation, but really we're looking at maladaptive thought patterns and trying to learn strategies so that ultimately people have a balanced perspective on things, so that they end up having a change in their behavior and change in their thought process, and ultimately a change in their mood. Behavioral activation is really about trying to have people more engaged in meaningful activities, socialization, often involves lifestyle changes, and it's very commonly used in the older adult population. Problem-solving therapy is really a component of CBT, and problem-solving is really about helping patients identify a problem, start to develop alternatives to the problems. They test out their approach to the problem, they evaluate it, and then you continue to reassess. IPT is informed by psychodynamic psychotherapy, but it's a little bit more structured. It's a shorter term therapy, and we look at specific roles. So what you'll may have learned about is that there's 4 specific interpersonal problem areas that could be considered. Probably the most common I see in older adults is grief and role transitions, but we also have available interpersonal deficits and interpersonal disputes. Mindfulness, this is a bit newer in the older adult population, but MBCT is looking at some kind of meditation here and now strategies, as well as integrate some cognitive behavioral techniques. And then reminiscence and therapy and life review is really about kind of going back and having people recall certain aspects of their life, trying to focus ideally on more positive aspects of their life and achievements. And it's not just through, it may be through talking, but it can also be through experiences, sensory stimulation. And so that just kind of gives you a general overview of these psychotherapies. So when it comes to the evidence, so if you look at just sort of general findings, there are systematic reviews, meta-analyses that have basically grouped psychotherapy together as a whole. So if you put the studies together, generally the findings say that psychotherapy can be effective for older adults, and it's comparable to antidepressant treatment. Depending on your control group, the effectiveness varies, with more moderate, larger effect size compared to waitlist controls. And the studies suggest that the effect size are not related to how patients were recruited, the depression of definition, or the type or length of treatment. When it comes to specific intervention findings, what you'll find is that CBT has not only been the most studied, but it's also found to be the most effective. Problem-solving therapy also has been found to be more effective in general. The direct comparison suggests that older adults tend to do better with more active, structured, kind of skills-based psychotherapy, so kind of more hands-on tasks and more directed, rather than the less kind of directive, more supportive counseling. Problem-solving therapy specifically is emerging as a preferred treatment for depression that's associated with executive dysfunction. So some older adults that have a little bit more cognitive dysfunction as part of, as a feature of their depression, as well as in people with more medical comorbidities, disability, chronic pain. And it's possibly more effective in the older adult population compared to our general adult population. There's less evidence when it comes to behavioral activation in IPT, which is sort of interesting because BA is part of CBT and we actually use it a lot. Whether we are aware we're using BA or not, it's actually often integrated into our assessments and consultation. And so just based on clinical experience alone, and I did do a little bit of extra IPT training during my PGY6 here, I did find it to be actually fairly effective. MBCT, there is a study that suggests that it's moderately effective, and reminiscence therapy, life review, there's not as much literature, and there's smaller to a moderate effect size, and it tends to be used in more, you can see it a lot more in the institutionalized population, but also kind of in the palliative care literature. There is some evidence for psychodynamic, but it is more limited. Often that relates to kind of the duration of the studies, and older adults, that can be difficult, especially when you have medical illness and things, hospitalization, things that come up that may influence their ability to take part in this intervention. So when it comes to late life anxiety, really there's actually less evidence compared to depression, but it's basically the evidence that is available shows that CBT can be effective, not quite as effective compared to when we look at the evidence compared to depression and how that compares to effectiveness for older adults compared to the general adult population. There's also some literature on mindfulness for treatment of anxiety. But the main concern really when we look at the literature is that it's limited. And as is the case for many things when we talk about older adults, we just don't have enough research. And so ultimately what you find when you scan the literature is that there's relatively small a number of high quality studies. There's a lot of heterogeneity. So some of these studies are kind of deriving conclusions from kind of a mixed population, and older adults are just part of, the overall study that includes general adults. There's less inclusion of older adults. So often, it's kind of upwards of 70, and there's really not much data capturing, what about our 80 plus, 90 plus age group. It's limited by direct comparisons to other psychotherapeutic modalities, as well as to psychopharm or combined treatment. We certainly blinding of participants is not possible, short study duration and follow-up. And so what we're left with is we actually have a lot of knowledge gaps. And so in general, we lack data for anxiety disorders. We lack data for looking at comorbid anxiety and depression, also for comorbid psychiatric and medical comorbidities, as well as, like I said, the combined psychopharm and psychotherapy for our older adult population. And the other thing that's really limited is not just whether or not we find psychotherapy or specific modalities effective, is there's really little guidance on the predictors and moderators of treatment outcomes. So basically, what are the active ingredients in this particular psychotherapy that is leading somebody having a positive response? Okay, so looking at indications and considerations for psychotherapy in older adults. So when you're thinking about psychotherapy, one of the things that you're going to think about is, well, what is their diagnosis? Do they have a diagnosis that may potentially be amenable to a psychotherapeutic intervention? So depression and anxiety, some of the most common, insomnia. So we do know that CBT for insomnia can be helpful, and there is some literature to support the use of CBTI in older adults. Other psychiatric disorders. So is there a personality disorder? Psychotic disorder, we know that, consideration could be given to, if, for example, someone has borderline personality disorder, perhaps using DBT. Psychotic disorder, CBT, psychosis can be considered. But most commonly, what you'll probably find in your practice is that you're considering psychotherapy for people with depression and anxiety. Other reasons that a psychotherapy is considered is there may be concerns related to pharmacotherapy. So often people have a poor response, or especially relevant to our older adult population, there's polypharmacy, perhaps there's issues with side effects and tolerability, compliance can be a concern. And ultimately linked to pharmacotherapy is it also could be patient preference. Many people don't want to add more pills to their already complex regimen of medications, or some people might prefer, depending on the reason that they're presenting, it may be more relevant to have psychotherapy compared to a medication trial. The other reason we might think about psychotherapy, and this is something to think about for all of your patients, is, well, what are the likely kind of precipitating and perpetuating factors that have brought this patient to me now? And so I often think about, well, why now, right? Even if the person has a history of depression and they now have a recurrence, or is this their first episode, always ask the question, why now, and what's going on? And you're probably used to in your consults looking at potential relevant stressors and changes in the months and years leading up to their presentation. And so I've captured here, I would say, probably some of the most common themes that we see. And so there's many changes that older adults face, and that includes physical health changes, people living with chronic disease, which often is connected to disability, change in their level of functioning, which can impact their ability to engage in previously enjoyed activities and socialization. Loneliness and social isolation is really kind of a hot topic, if you will, in the literature. Social isolation has been linked to many mental health conditions, neurocognitive disorders, but also many physical health conditions, and linked to all-cause mortality. And so I was at a conference actually by a geriatric medicine conference, and the geriatric medicine physician, the way he sort of said it, he thinks about it now is kind of social isolation is like the new smoking for older adults. So it's not good, is the bottom line. Grief and loss, understandably, is quite common. People losing spouses, siblings, close friends. Role transitions. This is a big one. So there's a lot of transitions that basically happen, going from going from work life to retirement. Change in family roles is a big one. Often what we see is older adults adjusting to now having adult children and not feeling that they have the same kind of purpose or role in their family that they've known for the last 30, 40 plus years. Changes in their social setting. A lot of people were socially connected through work, and now that they're on their own or they're no longer working, perhaps that same opportunity is not present. And connected to role transitions, I would say, is this sense of loss of meaning and purpose. And so it's not uncommon to hear your older adult population say, that they're really struggling at this stage of life to find something that gives them a sense of meaning and purpose. And so, we often spend a lot of time during our assessments trying to understand, well, what, in your earlier years or up until this point, what did give you a sense of meaning and purpose? And can we find something that will give you that same sense, or at least a similar sense of purpose at this stage in your life? Interpersonal difficulties, that's not unique to older adults. That can happen certainly for all of us. Cognitive impairment, so people that are starting to adjust to even normal age-related changes, but also kind of the early stages of cognitive changes, and that can make certain tasks and IADLs more difficult and needing more support in that regard. And some people have difficulty, accessing, reaching out for help. Certainly looking at kind of, people facing mortality. Some people have existential distress. And then the other common one is financial. So again, adjusting from kind of work life to retirement. Some people may or may not have pensions or savings. We all know that the cost of living is going up, but especially for older adults, when you're considering things like retirement homes, especially, this just may not be an option for many people. And so certainly this leads to a lot of significant emotional and mental distress. I have here listed what I would say kind of relative contraindications. It's not to say that there's an absolute contraindication to psychotherapy, but you want to be selecting people that are not only interested and keen, but are likely able to engage in psychotherapy in a meaningful ways that will lead to better outcomes. And so if somebody is severely depressed to the point that their concentration is so impaired, or they have pretty significant memory deficits at this point in time because of how severe their depression is, it's going to be very hard for them to attend or retain information. If they have declining health, certainly some of our severely depressed older adults are losing weight, they're not caring for themselves. That is not the time for psychotherapy. Anybody that's actively suicidal, unless you're, specifically, for example, doing, say, DBT, working on self-harm and SI, you're likely not going to, now is not the time for psychotherapy. Anybody with more severe cognitive impairment, and these are people that are likely have an established major neurocognitive disorder in the least moderate range. Severe personality pathology, not to say that it can't be done. Psychotherapy isn't an option. It depends also on the modality. Maybe somebody has comorbid depression, but also be in mind that it may ultimately change kind of treatment outcomes and how that dynamic works in psychotherapy. Active substance misuse, I would say, again, relative, if somebody's, for example, consuming alcohol throughout the day, and you're trying to engage in psychotherapy, you're going to have challenges with that, and more likely it would be helpful to address this substance issue first and then revisit the idea of psychotherapy. And same thing with kind of active psychotic symptoms. Ideally, that psychosis would be treated. So if somebody has, psychotic depression, they probably need to be treated first. And once they're a little bit more stable, then look at psychotherapy. So what to consider when, you're trying to select a specific modality. And this is a bit challenging in that, how do I know which intervention to pick for my patient? So, in the ideal world, if you had the choice of all the different interventions for your patient with depression, how do I know which one to sign them up for, if you will? And if you actually go to the data, there's very limited data suggesting, help guiding, whether this patient would be better suited to say CBT or PST. But things that you could consider are certainly, again, the diagnosis. So what is their diagnosis? Is there evidence to support the use of this specific psychotherapeutic intervention for their diagnosis? Think about associated symptoms and comorbidities. Perhaps if they do have executive dysfunction or medical comorbidities, maybe problem-solving therapy might actually be a better fit compared to cognitive behavioral therapy. One of the things that I probably look at most is the nature and the role of the likely precipitants and contributing factors. So for example, if somebody, presenting with grief and loss, for me, if I have access to it, I might likely choose IPT over, say, CBT, even though the person has depression and could potentially consider both. So that's, so those psychosocial stressors often can help guide which intervention may be helpful. The effectiveness, certainly you're going to look at the evidence to say is, am I going to you are more likely to choose an intervention that tends to have more evidence, but probably realistically, what often guides what we're choosing is whether we have access to it. And that's kind of the unfortunate reality, is that we usually don't have a pick of all the available psychotherapies. And so often we're just referring people to what we have available to us. Other things to consider is, is this patient psychologically minded? Are they more likely to do well in a kind of highly structured, task-based, focused intervention versus something that's more unstructured? And people might say, I don't want to talk about my past. I'd rather work on a specific problem. And so being aware of what the patient's preference, what their goals are, will also help guide which modality. So just suggested indications. And again, this is really based on kind of the literature and matching to specific diagnosis. In general, CBT is being used for depression, anxiety, insomnia. BA is being used for depression, although I would say that I would argue that you could probably use it for most things, including anxiety. Problem-solving therapy, also the evidence, it's been developed for depression. Again, I would probably argue that it has a role in anxiety as well. Interpersonal psychotherapy, also for depression, and then reminiscence life therapy, mild depression, cognitive impairment, and typically in the palliative and institutionalized settings. And so what you'll see here is that we actually have a lot of interventions that are listed for depression and less for anxiety or other indications for that matter. So when it comes to actually delivering psychotherapy for older adults, if you go to the literature, there's basically more literature on treatment outcome rather than process issues and adapt. How do we adapt content? And basically what we've done is we've taken what we have developed for the general adult population and we've made adaptations based on age-related changes for older adults, so kind of physical health changes. And really around the process rather than adapting perhaps the content. But ultimately, what the recommendations are is to simplify the content, slow content delivery with more repetition. So you may, instead of spending 1 week, for example, in your CBT program on a particular skill, you might want to repeat that in a few different sessions. The adaptation to sensory limitations is advised. So looking at larger print, making sure that people can hear, making sure people have access. You might want to consider when you're developing your program, is this wheelchair accessible? Is it on the first floor? Is there parking? Isn't there parking? Is it accessible from public transport? So there's so many different things to consider when you're developing a psychotherapy program for older adults. You'll probably come across, especially in your studying, this idea of what's called enhanced CBT. And basically what that is that it's using these adjustments or making these adaptations to kind of our standard CBT protocols for the general adult population for older adults. And this is basically what I was just saying. So you're simplifying the content, you're repeating, you're adjusting the teaching material to take into account sensory impairment. You might want to try different modalities, so not just kind of didactic. You might use manuals, flip charts, whiteboards. It's really important to include late life themes. So when you're doing CBT with a patient and you're trying to come up with thought records, and you're coming up with scenarios or examples that people are faced with that are bringing about kind of depressive and anxious cognition, you want to make sure you're using examples that are relevant to an older adult. So talking about work life as an example probably isn't relevant at this stage. You might want to talk about something related to kind of loss or physical health changes or adjusting to functional changes, as an example. The other thing that's a change compared to the general adult population is the recommendation to have sort of reminders in between sessions. So homework check-ins, so phone calls in between. You may need reminders about, the sessions themselves and a reminder of when it's going to be and the time, but also, how's it going with your home practice? Do you have any questions? And so ideally, the psychotherapists that are delivering this intervention will be available for phone calls in between and do check-ins for older adults. Okay. Any questions so far? Okay, I think we're going to have time anyways. So, psychosocial. So psychosocial interventions, this is probably something that you're already familiar with, something that seems pretty straightforward, but I want to spend a little bit of time on it because I think if there's anything that you take away from this presentation, I want to emphasize the importance of psychosocial interventions for several different reasons, which we'll talk about. So any patient that you have, whether it's a consult, whether it's a follow-up, kind of no matter what setting you're seeing this patient in, or for whatever reason they're seeing you, consider talking about psychosocial interventions. And that includes psychoeducation, and so to start off with, when you've completed your assessment and you're sharing your diagnostic impression and you're starting to make a recommendation, certainly psychoeducation about, what if you think they have a specific condition, whether it be anxiety or depression, and what that means and what that can look like for an older adult, and that this is a medical condition and that it can be treatable. It can instill hope by saying, you have a condition that's treatable, and let's talk about a plan to address this. So psychoeducation for all patients is important. Lifestyle, something that you guys would be familiar about, but again, kind of diet and exercise, substance use, ideally educating about what are the recommended healthy drinking guidelines for older adults. If you go to the Canadian Coalition for Seniors Mental Health website, there's actually a really used pamphlet for patients about what's recommended in terms of their drinking. When people ask about diet, obviously it depends on their own medical conditions, whether they have, heart disease or diabetes. But in general, when people ask, we talk about the Mediterranean diet, which has most evidence kind of for healthy aging, especially related to cognitive health. Exercise, that one seems pretty straightforward, but repeatedly, not just in the general adult population, but in the older adult population, that exercise is really critical for our kind of mental health, cognitive health, physical health. It's actually one of the most important strategies for maintaining mobility and mitigating falls risk. And when it comes to the question of, what should be the prescribed amount of exercise? When it comes to older adults, it's really unclear. First of all, we don't really have the literature to support exactly what that should look like. But the way that I think about it is you need to adapt it to whatever the patient in front of you is presenting with, what their mobility is like, whether there's falls risk. And for me, my approach is any type of movement is better than none. And so whether it's chair exercises, whether it's walking around your apartment with your walker, up and down your driveway for 5 minutes a day, I tend to encourage people to get outdoors because I think there's the benefits of the fresh air, but it doesn't need to be 60 minutes, 3 days a week. That very well may not be feasible for many of our older adults. And so I try and start small and make it achievable so that, using a 5-minute rule, for example, increases somebody's likelihood to giving things a try. I think sleep hygiene is important for all our older adults. I'm sure that you are used to getting complaints about poor sleep and I don't sleep well. I mean, part of that is psychoeducation around normal physiological sleep changes for older adults, but really emphasizing the importance of sleep hygiene principles. So limiting substance use, getting some exercise, bright light first thing in the morning, limiting screen time before bed, monitoring caffeine, really, really important. Engagement in pleasurable and meaningful activities. And so this, often we spend a lot of time on this, and this also kind of ties into some of the socialization pieces. If people are now retired or they've had a change in social roles for different reasons, how can we basically get people out and about and connected? And so things to consider are really looking at getting people outside of their home, whether it's connected with family, friends, or more structured programming, which is ideal and actually a balance of both. So I talk often about, okay, well, where am I? What are the local senior centers that are available? Are there day programs? Are there recreation centers? Can you join a gym, do aquafit? Any type of volunteer work. Volunteer work can be very important as far as that fulfilling that kind of sense of meaning and purpose. And so it's not uncommon in follow-ups to actually be Googling things for our patients to say, well, what about this? I just pulled this up. Because a lot of the times it's not even that they're necessarily unwilling. They just don't know, what's available or how to access it. And so instead of me actually writing a prescription for medication, I'm often writing down the phone number and name of the local senior center. And I see that actually as a critical piece of what we do. The other thing to consider, especially when it comes to grief and loss, is bereavement groups or kind of spiritual care. So kind of understanding somebody's religious and spiritual background can be important. A lot of the bereavement groups are run by funeral homes. And so again, exploring those options for your patients if the particular kind of stressor in their life is bereavement. I want to highlight this as well because the psychosocial piece, because I think probably most of you will be familiar, and if not, you'll become familiar when you're studying for your exam. But the most recent depression guidelines from the Canadian Coalition for Seniors Mental Health that were published last summer, there is a whole new section on prevention, as well as looking at the role for psychosocial interventions throughout the trajectory of a depressive illness. They also comment on, this can also be helpful for anxiety, but these are the depression guidelines. And so the focus is on depression. But essentially, there's a lot of literature now that shows that psychosocial interventions are important for prevention of depression, for subthreshold symptoms. So, why do we need to wait for somebody to become severely depressed before we intervene, right? Like, it doesn't make sense. Why would we say, let's wait until they meet criteria for a major depressive episode to offer something that could be helpful? So psychosocial interventions, even psychotherapy. So even some of the new guidelines and data suggest that for subthreshold symptoms, you may at that point even then want to start thinking about CBT or even bibliotherapy or some online CBT resources. So get people connected sooner so that we're not just treating once unwell, we're looking at prevention, which is kind of the direction of medicine anyways, is that we're working towards a lot of more preventative strategies. So what you'll see throughout the guidelines, and why I'm highlighting psychosocial, is because it says that it's important for all stages. The other reason why I want to emphasize psychosocial is because this is not just relevant to anxiety and depression, but it's relevant to healthy aging and it's relevant to dementia care. So if you look at sort of, for example, the Lancet articles that look at dementia management, this too is really kind of critical. Well, what are the potentially modifiable risk factors for dementia? And a lot of the psychosocial interventions are relevant to that. And so we know that older adults that exercise, that have a healthy diet, that are cognitively engaged, are socially engaged, have a reduced risk for dementia. So another reason to suggest this to all patients. The final point before we move on, because I'm really kind of emphasizing this point that I want to make about psychosocial interventions, is that this may be the only thing that you can do, right? So in a perfect world, we would have access to all the different psychotherapeutic modalities in our clinics, but in reality, we don't, right? So most of us, maybe at most, if we're fortunate, have access to CBT, but a lot of us don't have access to IPT or psychodynamic for various reasons. And so but this is something you can do. You can make these recommendations in the absence of having access to any other psychotherapy. And so quite commonly, as part of my assessments, I take almost a behavioral activation approach at the end and talk about I know that I'm either not able or the patient's not interested, or for different reasons, I can't get them to CBT or a formal BA group. But I can ask them, do you have a calendar? Okay, let's get your calendar out. Let's pick a few activities that you could do throughout the week. Let's book in your walking like we would as if it's a doctor's appointment. I always talk about setting small goals that are attainable, right? If we set the goals too big that aren't realistic or not attainable, people don't do it. And so I often use the 5-minute rule, which I find really helpful. Can you walk for 5 minutes? People are very overwhelmed. I need to clean out my closet or something. Can you do it for 5 minutes? And so challenge people to start with small time increments or only a part of a specific task, because that builds kind of their confidence and their ability to do it, and they're more likely to be successful. Just remember that, this should always be included in your assessments and recommendations, and that you can start it in your office, whether or not you have access to formal psychotherapy. Any questions on this piece?
I noticed that you said the word social, or the word social prescribing, quite a bit. It seems like such an important concept, and it seems like it's grown more and more popular over the last years. And I kind of wonder, is this something that's kind of evolved out of COVID, because we're recognizing how isolated our patients were and how terrible that was? Or is this a concept that's been evolving in the literature for quite some time and we're just hearing more about it now?
Yeah, I would say both, because because the guidelines are based on data that was already available pre-COVID. And so, some of it's in the primary care literature that this social prescribing is really about, like prescribing people to go out and get connected to whatever volunteer work, recreation centers. But I do think that COVID just amplified, how social isolation, the impact it can have on, all of us, but especially our older adults. And I think that it's just become that much more apparent, and we've had to become more creative in the pandemic with how we're going to get people connected when, by definition, you're socially isolated, right? And so I do think people are more aware because of COVID, but it was already, I would say, recognized, because it's also very closely tied to the dementia literature, which has also been in the works for several years. I wanted to include just some useful resources that I often recommend to patients, or I refer to myself. And these are things that for people that either are interested in prevention, or they've got mild or sub-threshold symptoms, even moderate symptoms. So especially, we're usually faced with wait times, as you know. So often I recommend the book, and you guys may have become familiar with this throughout your training, but Mind Over Mood, which is a really good CBT book for depression. I also really like the 10 Simple Solutions series. So 10 Simple Solutions is a very kind of reader-friendly series that cover the different anxiety disorders. So I use the 10 Simple Solutions to worry for our older adults because it's often generalized anxiety that we're dealing with. There's also a chapter on procrastination, which is really helpful for many people. But just so you know, this series also has ones for panic, for social, but for older adults, I tend to use the 10 Simple Solutions to worry. Then there's a few websites where you can get access to CBT. Ability CBT, I believe, was offered free during the pandemic. I was actually checking last night. It looks like you now have to pay for it. And same with Anxiety Canada. So both of these websites, you can register and do CBT courses upwards of 12 weeks. It looks like the cost is around $500, but it is available. And you get connected with a therapist or a group through the online programs. As I mentioned, I usually talk to people about sleep hygiene. Providing people with sleep hygiene handouts, having that as part of your practice, I think can be really useful. There is a CBT online resource. I learned about this through the CAGP online course, actually, the My Sleep Well. So that's for CBTI. Some of you are probably likely familiar with the Fountain of Health initiative. Dr. Cassidy out in Dalhousie is the founder of this website, but really it captures so much of what we're saying about the psychosocial. And so there's different kind of modules and talks about different apps for healthy aging strategies. So it covers the social piece, the cognitive engagement, the exercise, the positive psychology. So it reviews all that. So it's a really useful website to refer people to. Certainly, we often recommend mindfulness apps like Calm. In the pandemic, these last two things became really quite useful. So I can't speak to, I don't know if this is the case for all provinces. I know that in Ontario that a lot of our senior centers developed what was called Senior Centers Without Walls. So instead of being able to go, they actually basically transitioned everything by phone. And so they had, telephone coffee chats and telephone bingo. And so, so they basically transitioned that to so that people can do it remotely. And then a lot of the virtual activities certainly sprung up during the pandemic. So museums, painting, yoga, exercise, no matter what it is, there was a lot of things that became available during the pandemic. So these are some of my kind of standard resources that I recommend for patients and families. Okay, so just to wrap up, I think it's always important to consider, well, what are our current challenges and what are sort of maybe potentially some future directions? And I don't need to tell all of you, we know that we have an aging population. And so what that may mean is that we have more older adults accessing mental health support. And so it's going to be important for us to be aware of, well, what are our potential options in terms of supporting patients and what treatment is available to them. One of the biggest challenges, or well, I guess the main challenges I would say, is that we have a lot of knowledge gaps. And so we need more research in this area to learn more about our psychotherapies and which current interventions are effective and what adaptations do we need to make, or do we need to actually develop new modalities altogether that better target the needs of our older adults? Medicine is headed in the direction of personalized care, and this idea of, well, does it make sense to just match people up to an intervention because they have a specific diagnosis, or do we need to be considering all these other things, like the reason that they developed this depressive episode in the first place? Should we be looking at targeting a specific problem rather than a specific diagnosis? The other major challenges, as you know, is resources are scarce, and that's economic, and probably more than anything, it's human resources. We don't have the manpower available to deliver these interventions. Psychiatrists are doing it less and less often. Psychologists, a lot of the times do a lot of psychotherapy, but that may be limited. Many have private options. That's not an option for many people. And so the resources just aren't there in many settings. And that really is also tied into accessibility. And so a lot of people aren't living in centers, like academic centers or tertiary centers where they have a choice of psychotherapy. A lot of people aren't, are living in communities where it's really just not available, or they can't access it for other reasons, maybe for their health reasons, maybe because of sensory impairment, mobility concerns, they don't drive. And so really kind of, future considerations or future directions is looking at how do we select which is the most appropriate intervention for the patient sitting in front of me, and how, knowing all of these constraints, economic, human resources, how do we have more people access support given these constraints? And so kind of what the literature, if you review the literature, really sort of what they're suggesting is that, are we headed in a direction of trying to create more personalized care, and even coming up with new psychotherapeutic interventions that maybe are CBT informed, but really target the specific needs of older adults. And so instead of saying, this patient has depression, therefore they're automatically going to CBT because that's what has evidence or that's what I have available to me, should we be looking more at, what are the specific needs and problems for older adults, and what is the best approach to address that problem? Because what we know is that we all have life stressors, but we don't always have the same reaction. And for some people that are faced with a physical problem, let's say that changes their functional ability, for some people that might result in depression. For some people that might result in anxiety. Same with bereavement. For bereavement, some people that might result in depression. For some people that might result in anxiety. And so should our interventions be tackling the problem of, for example, social isolation, and not just, and you can have anxiety and depression and still be relevant, you can still go to that whatever intervention is, because you're basically trying to address the problem that led to your symptoms to begin with. And so along those lines, I think that we could be looking at more transdiagnostic interventions where you do have anxiety and depression, and that could be a CBT for anxiety and depression, and really you're trying to target.
Yeah, how are you?
Or do you mind just muting? Okay. The other thing to consider when we're, trying to tackle resource constraints, and I've basically kind of already touched on this, is how else can we deliver psychotherapy? So certainly in the general adult population, there's a lot of literature about, can we do more groups? Can groups be offered in shorter sessions, 6 to 8 CBT compared to 12 sessions of CBT, so that it can be offered more frequently throughout the year? Can we do this by telephone and internet? Certainly, I think we're going to see more literature coming out of the pandemic, where a lot of people have shifted their groups to virtual. The other thing I think we're going to see more of is stepped care. And so, some people might do better with psychosocial interventions alone and never need the more extensive CBT group. And so what we might see, because of resources or patient preference or lots of other reasons, is you start with one thing, see how you do, and then if needed, you go to the next level. The other thing is, having other healthcare professionals deliver psychotherapies and not necessarily psychiatrists or psychologists. We certainly know that there's a lot of different allied health that do psychotherapy, but I think that training people in different settings, including primary care, where we're looking at prevention, I think will also be critically important. Okay, so to summarize, we know that psychotherapy can be effective for late life depression and is comparable to treatment in the effect size in the general adult population. We know that the active, more skills-based is likely more effective than the less directive psychotherapies for older adults. There is support for CBT for anxiety in older adults, but it's less robust. We want to recommend psychosocial interventions for all of our older adults. And we know that we have an aging population, which, yes, there are challenges that come with that, but also I think this presents a lot of opportunity. And certainly my hope that we'll see more growth in this area, and that instead of our approach of just, take what exists and try and modify it to older adults, really learn more about what our older adults need and develop new interventions that really best supports them. And then I have references. So thank you for your attention, everybody. I hope that covered the objectives, and certainly open to any kind of questions or comments or share your experience. And Dr. Gojmerac, if there's anything you wanted to add up front, please jump in.
So I have a question and a comment, but I'm just going to open it up to everybody else. If anyone would like to ask a question or make a comment, talk about their experience, or use the chat function, by all means, please do so. Okay, hearing no questions or comments and not reading any, I'll just give you my situation where I am, and I would say I'm in a low resource area. And I think that in geriatric psychiatry, there was a big presence of day hospitals throughout the country for quite some time. And I feel like slowly they're shutting down. And with that, I think we've really lost something, because we're losing a lot of the social interaction. People are often very isolated, and the behavioral activation, a lot of that's gone now. And I think that there was an opportunity for psychotherapy of some form in many of these day hospitals. And I used to do a CBT group for elderly people, but I found that in my day hospital, the population was too heterogeneous. So people would come in, they kind of be there for like support and psychoeducation. But when it came to like that psychological mindedness and the motivation to do homework, it just wasn't there for all those patients. And the more I read about problem solving therapy, I'm wondering if that's kind of a direction to go in. Like when you have, you know, limited resources, you might want to involve residents so they can learn psychotherapy, but you want to meet the needs of patients. I kind of wonder if that might be a direction that I could take, for example, our day hospital in.
I mean, I think so. So truthfully, like I'm not trained in problem solving therapy. I just kind of have learned about it through the literature and studying, but I agree with that. I mean, really, because even in your standard CBT protocol, there's usually 1 or 2 sessions on problem solving. And, and so it actually makes sense to have a more expanded version of that. And because it's so kind of hands-on, task-based, it's directed, you have clear goals. A lot of the times I think it's content that people can grasp more. And a lot of times people, you know, whether they're presenting or anxiety or depression, a lot of the times people are presenting because they're stuck, right? There's a problem that I can't navigate, or that I'm having difficulty navigating. You know, I used to do things a certain way. And this is where a lot of like that all or nothing thinking comes in. I'm so used to, you know, I always did this way, but now I have this health change and now I can't do it at all. And a lot of that is really, well, like, how do we solve that problem and learn about trying something in a different way? Just because you're doing it differently doesn't mean it's bad or worse. It just looks different, and it doesn't mean you can't do it at all. And so I think that, you know, the problem solving piece is really important, and that even can be connected to your behavioral activation, because, you know, a lot of times people are, well, I would like to be more social, but I don't know what to do, right? And so there's a lot of guidance and brainstorming around, well, what could you do? Like, could you call so and so? And could you, you know, if you wanted to learn about what library programs are available, well, how would you find that information out? And then you develop an action plan, you know, and you work through it, you test it out. And so I agree. I think I also agree about the point about the day programs. I don't see them really anymore, but I do think that there's going to be a greater need for problem solving, or I think we'll see more of it. And, you know, some of the studies are showing that, you know, could this be one of our most effective or more effective interventions for older adults, and even more so compared to the general population? Now, I didn't really get into detail in the kind of comorbid medical population, but I know that that's being looked at also in that group. I don't know, Dr. Gojmerac, if you have any kind of thoughts on that question or comments about that, or anything else we talked about.
Yeah, for sure. Yeah, I'm less familiar like with the ins and outs of problem solving therapy. I guess for me, my go-to, if you're not going to do CBT, would be BA, because I think you get the biggest bang for your buck. You're covering mental health, but you're also hopefully adding behaviors into a person's daily life that might prevent cognitive decline in the future. So I think that there's just more to offer from BA, in my opinion. And the other kind of go-to, I would think that's a bit more concrete and perhaps helpful, is the mindfulness-based intervention, because most people can understand that, and you could, you're not working around any issues with cognitive impairment or the inability to kind of modify cognitions. So those would be kind of my go-to if I wasn't going to be doing CBT with somebody.
Okay, excellent. Thank you. I'm just conscious of the time. I think we have 1 minute left. So I just really want to thank everyone for showing up today. Thank you so much to Dr. Hanley and Gojmerac for presenting. I really appreciate your time, and I'm so appreciative of the fact that you allowed us to record so that this session will be available to residents on the Geriatric website, which is from McMaster. So thank you, everybody. As soon as that recording gets onto the website, I'll let you know, and I will also send out an evaluation. So everyone have a great day, and thanks for joining.
Thanks, everyone. Nice to meet you.
Nice to meet you.